Okay, so this last part of Chapter 8 focuses on a couple of select synovial joints, and then briefly discusses some of the ways in which we can kind of screw our joints up, unfortunately. So actually the first of the select synovial joints that we're going to talk about is the one shown here, which is the knee. The knee is actually an incredibly complex joint, and the most complex joint in the body, and that's because it's really not just one joint, it's actually three joints that are in this one kind of synovial cavity. So there's the joint between the femur and the patella, so the femoropatellar joint, that's a plane joint. So just a little more of that kind of gliding, kind of little bitty motion, particularly during knee flexion. So if you were to flex your knee and then put your hand on your patella, your kneecap, you'd be able to kind of slide it across the surface of the femur just a little bit. And then there's actually two joints between the femur and the tibia. So between the lateral and medial condyles on both the femur and the tibia. So you have a connection between the lateral condyle of the femur and the lateral condyle of the tibia, and then a connection between the medial condyle on the femur and the medial condyle on the tibia. Now that part of the knee joint is a hinge joint. We like to refer to it as a modified hinge joint because if you kind of partly flex your knee, just like a little bit, you can sort of rotate your leg then, but not really a whole lot. Not like you could rotate your shoulder or your hip. So it's kind of modified hinge. We're still mostly talking about flexion and extension of the knee. So this is what the knee looks like. Kind of from the side view, we'll look at it through a sagittal section. You can see here's the femur, here's the tibia, here's your patella, kind of sitting on the patellar surface of the femur. You can see there are some bursa here, some fat pads that help kind of prevent some friction through and around and under all of these ligaments. You'll also see there are ligaments here, kind of in between the two bones. These are what we call the Cruciate Ligaments, and we're going to talk a little bit more about them in a little bit. You'll also see what we call the menisci. So the menisci are these kind of fibrocartilaginous pads that sit between the femur and the tibia. Both the femur and the tibia still have their articular cartilage, but then they have these pads of fibrocartilage with them as well. Here you can see, now we're looking down on the top of the tibia, and you can see here's the lateral meniscus, here's the medial meniscus, these kind of moon-shaped pads of fibrocartilage that then sit on top of the articular cartilage and kind of around the articular cartilage on the tibia. Here again is our Cruciate ligaments. And they've been cut away, so you're only seeing part of them, but you'll see they do kind of cross over here in the interior of the joint cavity. There are lots and lots of bursae here because there are a lot of ligaments and tendons in this area, particularly your quadriceps tendons and your hamstrings muscle tendons. The quadriceps is the thigh muscle on the anterior, the hamstrings are the thigh muscles on the posterior. That's really a good stabilizing force with this knee because the capsule itself is pretty thin and in fact is completely missing on the anterior part of the knee joint because instead of the joint capsule and the two kind of synovial membranes there, what we have are the patellar ligaments and then these two patellar retinacular ligaments laterally and medially that branch off of the quadriceps tendon. So here I'll show you what that looks like. So here's your quadriceps tendon, and you can see here's your big quadriceps femoris muscle, your big thigh muscle. Here's the patellar ligament. So the patellar ligament actually stabilizes the patella and attaches it to the tibial tuberosity here on the tibia. But then what else helps stabilize the patella kind of in its location on the patellar surface are these retinacula, and you can see they're basically extensions of the quadriceps tendon. that connect the quadriceps muscle to the tibia, but then they also connect here to the femur. You'll also see two what we call collateral ligaments in this image. You have a tibial collateral ligament that goes from the femur to the same side on the tibia, and then a fibular collateral ligament that goes then from the lateral side of the femur to the fibula down here. And they're helpful in particularly preventing some of that kind of side-to-side motion that we don't do very well with our knee. So we have the collateral ligaments I just pointed out, and then we also have what we call these popliteal ligaments. We have an oblique one and an arcuate one, and these are on the posterior side, the back side of the knee joint. And both the collateral ligaments and these popliteal ligaments are very much helping you do, or helping you not do, actually, what we call hyperextension of the knee, right? So if you were to do a back bend, you can hyperextend your intervertebral joints, but you can't really hyperextend your knee very well, right? Your knee doesn't kind of come up the way the other way. It really just does the flexion and extension. So here again, you can see the collateral ligament, again, going from the femur to the tibia, and then from the femur to the fibula. But then you can also see here's these popliteal ligaments, the arcuate popliteal ligaments, going from the fibula to the femur. And then here are these oblique popliteal ligaments that are really kind of almost wrapping around the back of the knee, going from the tibia side over here to the femur. And then you can see lots of different muscles. You can see some of the tendons attaching these and kind of further stabilizing our knee joint, all these tendons from all these different thigh and calf muscles. So the popliteal ligaments and, the collateral ligaments are capsular or extracapsular, but then we also have some that are actually inside the joint capsule, and those are our two cruciate ligaments. And they really help prevent what we call anterior-posterior displacement. So where you don't want your femur kind of sliding ahead of your tibia, you don't want your tibia sliding ahead of your femur. So you really want to keep them in line with each other, and the two cruciate ligaments are a huge part of that. So here you can see here is the posterior cruciate ligament, which essentially goes from the kind of inside the almost anterior part of the femur to the posterior side of the tibia, and then you have the anterior cruciate ligament, which goes from the back of the femur to the front of the tibia. And so cruciate means cross, so these ligaments cross over each other inside the knee joint here. Again, you can see here's your collateral ligaments, here's the fibular collateral ligament, here's the tibial collateral ligament. Here I've peeled away the patella so you can kind of look inside the capsular space and see those cruciate ligaments. In terms of damaging your knee, in terms of putting like weight from above, the knee is really good about absorbing what we would call vertical force, but it's the horizontal kind of trauma that is kind of especially damaging. So you can look at what they call the 3 C's, and it's typically going to be, if something tears in your knee or breaks in your knee, it's typically going to be one of these collateral ligaments, or one of the cruciate ligaments, or one of the cartilages, one of the menisci. I actually tore my ACL. It's a very common sports injury when you put kind of this lateral trauma on your knee. So that's it for the knee. The shoulder is not quite as complicated, although it's we're primarily just talking about the ball and socket of the head of the humerus with the glenoid cavity on the scapula. It's an incredibly freely moving joint in your body, and in fact the most freely movable joint in your body, in part because the scapula is not really tightly attached to the vertebral column and the thoracic cage, but also that glenoid cavity is very shallow. There really aren't a lot of ligaments in this area, and so you have a very large range of motion when it comes to your glenohumeral or shoulder joint. So here you can see, here's the head of the humerus, here's the glenoid cavity of the scapula. They both still have their articular cartilage. You will see a lot of bursae here. There are ligaments connecting all the different parts of the scapula. So you can see we're missing the coracoid process here on the scapula in this picture, but you can see there's a ligament that goes from the acromion of the scapula to the coracoid process, and all of those kind of pieces that stick up from the scapula are connected by ligaments, and so you will see a lot of these bursae or fat pads. You'll also see a lot of tendon sheaths in this area. The kind of main stabilizing force for your shoulder is actually, like it is with many of your synovial joints, but especially here in the shoulder, a lot of these tendons that attach to shoulder muscles. The one that you're seeing here is the biceps brachii muscle, and you can see here's the tendon sheath that kind of wraps around it. Again, friction reduction. So most of the ligaments that are there are kind of mostly towards the anterior, the front of the shoulder joint, not really a whole lot in the back. You have the Coraco-Humeral Ligament, which goes from the coracoid process on the scapula to the head of the humerus, and that's really important, particularly like when you hold up your arm, kind of like helping support the weight of that is the Coraco-Humeral Ligament. And then on the very anterior part of the shoulder joint in the joint cavity, you have the glenohumeral ligaments, which goes from the glenoid cavity to the head of the humerus. But they are not very strong ligaments, and in fact in some people are actually absent and not present, and so they're not they help stabilize the joint, but they're not playing a huge role, which again means that the shoulder is very freely movable. It is really primarily the muscle tendons that are giving any sort of stability that the shoulder has at all, is usually due to these, particularly the biceps brachii muscle, which the tendon of that, one of the biceps brachii origins, basically threads through the two tubercles on the head of the humerus and go right into the glenoid cavity. So it really helps like attach the humerus to the glenoid cavity. And then if you've ever heard of the rotator cuff, the rotator cuff is 4 muscles: the subscapularis, the supraspinatus, the infraspinatus, and the teres minor, where the tendons for these 4 muscles basically wrap around the shoulder and a huge stabilizing force for the shoulder. If you tear your rotator cuff, you can very badly damage your shoulder. So here is the tendon of the biceps brachii. Again, it goes through that. Here's the one tubercle. It goes basically the other tubercles around here somewhere. It kind of threads through the tubercle and attaches it into the glenoid cavity. You can see here some of our glenohumeral ligaments, again going from the glenoid cavity to the head of the humerus. You can see here's the Coraco-Humeral Ligament, so from the coracoid process on the scapula to the humerus. Again, really helps supporting like the weight of the limb. Here's subscapularis muscle. I think that's all you can see here in terms of the rotator cuff. There we go. Now you can see here's the glenohumeral ligaments. They've been kind of cut so we can see them. Here's the tendon for the biceps brachii muscle. You can see it kind of wraps in there. And then you can see here is the tendon of the subscapularis muscle, and you can see it just kind of wraps around and helps stabilize the very unstable shoulder joint. So those rotator cuff muscles are really quite important, which is why if anybody's ever heard, you talk about this athlete tore his rotator cuff and could no longer play his sport or whatever, because it really is a huge stabilizing force for your shoulder. In terms of the elbow joint, we're talking about the two bones of the forearm, radius and ulna, with the bone of the arm, the humerus. The elbow is a hinge joint. What is really making the hinge of the hinge joint is the trochlear notch of the ulna, with the trochlea on the humerus. That does then flexion and extension. You'll also see, so here you go, here's your trochlear notch, here's your trochlea, so here's the ulna, here's the humerus. That's really what's like making the hinge part of your elbow. Here's your elbow, right, your actual elbow when you put it on the table. That's your olecranon. There are, again, some, and there's always our articular cartilage. There's usually some bursa. You can see here's the tendon of the brachialis muscle, tendon of the triceps muscle. They help stabilize this as well. The elbow joint doesn't have a lot of ligaments. We have the annular ligament, which goes around the radius and attaches the radius to the ulna. It makes like the sleeve for the proximal radial ulnar pivot joint that allows you to do pronation and supination. And then you have two collateral ligaments that really prevent, excuse me, that kind of side-to-side movement, right? Your forearm bones don't kind of rock side to side against your humerus, so they really are just kind of moving in that kind of sagittal direction, flexion extension. So you have a collateral ligament that connects the humerus to the ulna, that's the ulnar collateral ligament, and you have a collateral ligament that connects the radius to the humerus, which then is the radial collateral ligament. So here's the annular ligament, again making the sleeve for the pivot joint around the proximal radial ulnar joint. The head of the radius actually goes to not the trochlea on the humerus, but the capitulum, and kind of just rests against the capitulum so that the radius can rotate inside the proximal radial ulnar joint. Here then is your articular capsule. You can see here's the radial collateral ligament, and if I look at a medial view, then you can then see the ulnar collateral ligaments, and again the annular ligament for the proximal radial ulnar joint. So that's it for the elbow. It's not super complicated. The next one we're going to talk about is the hip, or the coxal joint. Like your shoulder, it is a ball and socket joint. It's the head of the femur with the acetabulum on the coxal bones. It is still a multi-axial joint, so it's still a ball and socket, right? We can do flexion, extension, abduction, adduction, rotation, but the range of motion on the hip isn't as large as it is on the shoulder, in part because the acetabular socket on the hip is so much deeper than the glenoid cavity on the scapula. And then not only is the socket deep to start with for the hip, but then we get what we call the acetabular labrum, which is basically like a little buildup of fibrocartilage, which makes the acetabular socket even kind of deeper. So it's very, very, very unlikely that can of course still happen, but unlike dislocating a shoulder, dislocating a hip is quite difficult to do. So here you go. Here you can see here's the head of the femur into the acetabulum of the hip, and you can see here is this acetabular labrum that really enhances the depth of this socket. So it takes a lot to dislocate a hip here. There are lots of ligaments actually in the hip joint. They tell you right in their name what bones they connect. So iliophmoral ligaments connect the ilium and the femur. The pubofemoral ligaments connect the pubis to the femur. The ischiofemoral ligaments then connect the ischium to the femur. And then you also have the ligamentum teres, which I think you can actually see in this instance right here. This actually goes right into the fovea capitis on your femur and contains a blood supply for the head of the femur here. So here is our some of our iliofemoral ligaments, again from the ilium to the femur, ischiofemoral from the ischium to the femur, and then the pubofemoral going from the pubis to the femur. And here's another kind of anterior view of the iliofemoral ligaments going from the ilium to the femur. The last joint that we're going to look at in any detail is what we call the Temporomandibular Joint, or TMJ. It's those mandibular condyles with the mandibular fossa in the temporal bone. The TMJ is considered a hinge joint, so you can open and close your mouth, you can depress and elevate your mandible, your lower jaw. You can also get a little bit of kind of side to side, what we call lateral excursion. That's how we kind of grind our teeth. And it's mostly about chewing when it comes to elevating and being able to grind our teeth like that. It helps us chew. The TMJ is unfortunately very, very easily dislocated, quite the most easily dislocated joint in the body. Again, think of, boxers, right? Boxers dislocate their jaws all the time. That's why they often have speech impediments if they've been in boxing for a while. Because here, if we look at our condylar process on our mandible and the little fossa on the temporal bone, you can see it's really, really shallow. It's a really shallow connection. We just have one ligament, the lateral ligament right here. So it's very, very, very easy to dislocate the TMJ. Typically, TMJ dislocations are an anterior dislocation, so basically your mouth kind of hangs open because the front jaw, the lower jaw, kind of hangs forward, and then to get it back into place, the doctor or whoever is going to treat you basically puts their hand on your lower jaw, on your mandible, and basically shoves it back into place, which sounds just terrible in my opinion. We've talked a lot about dislocation